Good morning, ladies and gentlemen. We're going to start our next session, and it'll be on bipolar disorder and a pragmatic approach to the comprehensive management of bipolar disorder. And we're lucky to have Professor David Castle, who's the Professor of Psychiatry at St Vincent's Health and University of Medicine, and he's come up from Melbourne to present to us today. And it's going to be in a few segments, this talk, and David will encourage you to ask questions at the end of each section rather than having a question time at the end. So I'd like you to welcome David Castle. Thank you.
Yeah. Well, thank you so much, and the weather is better here, I should say. So as we heard, what we're going to do is to break this up into a number of segments, because we've got an hour, and that's rather long for people with short attention span like me. So I'm going to start off with a segment about bipolar and what bipolar sort of is. And there are some changing conceptualizations of this. And for those of you in Newcastle, you will know about this game called rugby league, which is not proper rugby, of course. I disagree with that. Yeah, but you're wrong. Because where I grew up in South Africa, of course, it's rugby union, which is God's game. But the other thing about, as a caveat to this talk, being South African, I managed to insult everybody in the room by the end of the talk. So the reason I mentioned rugby league is that there have been sort of some celebrity bipolar, so-called bipolar, associated with that code in particular, and obviously not naming names. But I think that there's an issue for the field here as to how much you get creep in terms of diagnoses. And unfortunately for our field is that all of the constructs which we have are fairly loose. And what we're seeing now is some people, I think, overdiagnosing bipolar, and bipolar has some sort of cred and is associated with creativity, and also sometimes is used as, to my mind, a bit of an excuse for not such good behavior. And I think we need to be careful about this, and we need to be careful about this especially in the face of the fact that bipolar itself, at the pointy end of bipolar, and I'll explain what I mean by that, is a very difficult and very disabling condition unless it's adequately treated. If it's adequately treated, it's one of the most rewarding conditions to be associated with in terms of a therapeutic association with an individual with bipolar, because people with bipolar are often very, very motivated, mostly very motivated to get themselves stable and to get themselves effectively managing their symptoms. Unfortunately, the other side of overdiagnosis is underdiagnosis, and sometimes bipolar diagnoses can be missed, and in our own work we found that up to 10 years can be missed in terms of people with bipolar not getting adequately treated. And that's especially true of what is referred to as bipolar 2, which is a smaller, slightly less severe variant of bipolar. So some of the nosological things are a little bit complicated and a bit changeable. So I'll try to depict that. This is actually from a textbook I did with Daryl Bassett. And what it shows is that if we look at this phase of mood, the so-called manic phase, and this the so-called depressed phase, most people follow that blue line, and we've got ups and downs. I don't know anybody, maybe our chairperson, who would follow that black line, which is like perfectly stable at all times. But somehow it's very unusual. So what you can see is that at this end of this spectrum, if you like, if you see this as a spectrum, you've got a very severe perturbation of mood, and this is referred to as bipolar 1. And bipolar 1, the diagnosis is actually driven by the manic pole, and this is one of the debates in the literature. A lot of people say actually the diagnosis initially constructed was about the episodicity rather than necessarily driven by the manic pole, but as we have it, it's driven by the manic pole. And even if you only ever have mania and repeated mania, you still technically meet criteria for bipolar, which is a bit of a curiosity. There used to be unipolar mania, And some people only ever have manic episodes. About 20% of people may be with so-called bipolar. But technically, they're bipolar. And this poll is very, very recognizable. It's driven by the core elation or elevation in mood, so it's an elevated mood state. And now what's been more and more appreciated is the motor drive, and adrenaline-driven motor component, associated, of course, with a whole lot of features which will be, again, recognizable to you. They include that your thoughts race, that means you talk very quickly, often talk very loudly. You tend to be over-intrusive. You tend to get also, as an admixture to all this, very irritable. And it would be relatively unusual for people to just be purely elated and lovely to be with, and the life and the soul of the party. The bipolar is a little bit different from that. There's often an irritability associated with it. And if you get, especially because people have this elated, grandiose belief in themselves, if you try and stop them, they become very angry. I have a patient whose husband has bipolar, and they're not very wealthy people, I should say, went off to Sydney, you know, that den of vice, to the north. And there they were walking down the street in Paddington, which is quite an expensive suburb. It's a very arty suburb. So there was an art gallery, and they don't know anything about art very much anyway. But this chap decided he was going to go and buy a painting, so he walked in and bought a mega oil painting for about $3,000. And his wife said, "We don't actually have an art collection, we don't have an interest in art," but he was insistent. So she thought, I know what he's like, I'm not going to stand in his way. So she let it go, and he was very happy and bumptious, and they went off down the road. And then unfortunately they came across a house being auctioned. And he decided that even though they had a house in Melbourne and they still hadn't paid it off, they did need a house in Sydney. So $2 million worth of auction bidding later, his wife said, no, we can't buy this house. And then he exploded, and there was a big scene, and he got taken off to hospital. So sometimes this can occur, and it can be very tricky for family actually to know when to intervene and how to intervene, because often they can cop it. I've indicated one of the associated dangers and risks associated with the manic pole is that people overspend. So if you're managing people with bipolar, you really got to put things in place about credit cards. I had another patient who, all things are relative, I should say. So I had a patient who I was seeing just for a colleague, and I'd never met the lady before, and she came and she was very beautifully dressed and a little bit over the top and quite chatty, a little bit seductive. And I thought, oh goodness, she's on the cusp here of becoming unwell. And so I said, so have you been out spending? And she said, yes, I like to shop. And I said, so what have you been shopping at? And she said, well, she lived in a suburb called Toorak, by the way, which gives you an indicator here. She said, well, I went to buy some clothes. And I said, how much did you spend today? And she said, $10,000. And I thought, goodness. I said, when you go home, I want you to give your credit card to your husband, and I also want you to take some extra Seroquel, as it happened. I'll see you first thing tomorrow morning with your husband, and we'll take things further. Anyway, she came back next morning, and she was a little bit more settled, and she'd had a good night's sleep, and everything seemed to be reaching some sort of equilibrium. And I said, what about the credit card? And her husband looked a bit puzzled and said to me, yes, well, she did offer me the credit card, and I didn't think it was necessary. And I thought, oh, this is a little bit delicate. And I said, did she explain to you what has been going on with spending? And he said, yes, she went shopping, but she likes to shop. And I said, do you know how much she spent? He said, well, not exactly. And I said, well, actually, she spent $10,000 yesterday on new clothes. And he said, oh, but she needed a new spring wardrobe. So as I say, all things are relative. You can appreciate, though, that some people can't afford that, and they think they can afford it, and they can get themselves into terrible trouble. The other area people get themselves into terrible trouble is people feeling, when people describe when they're manic, that every one of the opposite sex looks attractive and looks worth a go, and you'll get people getting into terrible trouble with sexual indiscretions as well. So these are some of the big risk factors. And also, obviously, you can get risk associated with your reputation. So that's how, those are some of the components to what the manic pole look like. I think one of the cardinal features, and which is cardinal in terms of diagnosis and cardinal in terms of therapeutics, is sleep. So this description of sleep is very, very specific for bipolar mania or bipolar hypermania, and that is that people have a reduced need for sleep. They've got so much going on in their mind, they've got so much goal-directed activity, they've got so many things to do, and they're so busy that they don't need to sleep. And to me, that's absolutely key diagnostically, also therapeutically. One of the key components of therapy is to get your sleep pattern back into sync as soon as possible. I'll explain more about that. Often, as I said, about 10 to 20% of people go on with just bipolar mania, but it's unusual. Most people also get the deep, dark depressions. And this is a bit misleading, this diagram, actually, because the manic poles are boom, up and down. They're treated because they're so obvious. The deep, dark depressions can often linger for a very long time. And the depression, there's no features associated with the depression in bipolar which makes it absolutely diagnostic of bipolar, but there are a number of features which you can bear in mind. Phil Mitchell in Sydney has done some nice work talking about probabilistic modelling. So what he says is if you see a patient with depression and they have certain features, you would start thinking that this might be a bipolar depression. One of the big features is if they've got a family history of bipolar. Always ask about family history because it's one of the most genetic of all the disorders which we have. The other is if they have an early onset of quite a severe depression. So late teens, early 20s, severe depression. The other are features of what's called melancholia. Melancholia is a rather archaic term, but now is used to describe features associated with, usually with severity, and they include things like early morning awakening, diurnal variation, so your mood tends to get better towards the end of the day, although some people, when they're really depressed, just have no change in their mood. And also psychosis, so if you had psychosis associated with your depression, and remember that these should be what are called mood congruent, that when you are depressed, you have nihilistic, guilty ruminations which can become psychotic, so you can believe you've done something terrible and deserve to be punished. And also what are called atypical features, which include leaden paralysis, which is like a motor slowing up, and also a lot of anxiety admixture. So these are the sort of features which make you start thinking this might be part of bipolar. Family history, early onset, psychotic features, melancholic features, and atypical features. They're not, of course, pathognomonic, but, as I said, probabilistically might point you towards a bipolar diagnosis. Okay, so that's pretty clear. That's bipolar type 1, and that's about 0.5 to 1% of the population, pretty consistent across studies. Then you can start getting into the other parts of this spectrum, and here is this thing called bipolar 2. Now, some people believe, for example, Gordon Parker in Sydney, it's very clear this is a separate disorder, and it's associated with a lesser extreme up mood. So it doesn't meet criteria for bipolar type 1. Bipolar type 1, by the way, you have to have at least 7 days of predominantly high mood, unless you treat it to meet DSM criteria at least. Bipolar 2 is a lesser, it's hypo, it's slightly not as severe. I always find this a bit of a curiosity, because one of the features which make you bipolar 1 rather than bipolar 2 is whether you get into hospital. Technically, if you're in hospital with an elevated mood state, that's bipolar 1 by definition, which is a bit ridiculous because, in Newcastle, you're going to get into hospital pretty quickly if you're running down the street naked, right? Yes. But in darkest Africa, you might not be so likely to get into treatment. So anything diagnosed according to treatment is a bit silly, but there's plenty of silliness in psychiatry, don't worry. And some people, and also, you could say, well, it's just a somewhat lesser form of this, and therefore isn't a separate disorder, but is on a spectrum of severity. My own view is that everything's spectra rather than discrete categories. But you will hear about this thing called bipolar 2, which is slightly less extreme up poles. The down poles are still quite nasty, and often very, very pervasive and prolonged. Then you start getting into the tail of this, and here you get things like cyclothymia, which is used to be called cyclothymic personality. It's people who sort of up and down quite a lot, but it's not quite as severe as the bipolar 2. So is it a personality disorder or part of your construct, or is it part of a disorder? Well, mostly we err on the side of calling it a disorder if it's severe enough to cause distress and or impair functioning and response to treatment, right? And then you can see you get really down to the tail of this and ask yourself, well, what is normal and what is abnormal in terms of mood and perturbations of mood? And there's no clear answer to where one begins and ends with these things. There's this notion, coming back to this sort of part of it, is to say, well, maybe people here have actual problems with regard to their mood, but it's not quite meeting criteria. This has been called sub-threshold bipolar. This is from Kathleen Marikangas, and what she's done essentially is to say there are these people who don't quite meet criteria for bipolar according to DSM, but they're almost there. And if you look at these people, so for example, sub-threshold hypomania with not quite as many criteria, and they also get a bit depressed. It's this sort of idea. And if you use this sort of approach, you can get quite a lot of people in the general population having bipolar or bipolar spectrum. So as I said, bipolar 1, pretty ubiquitous from across the world, that's a clear 0.5 to 1%. Bipolar 2 in this study, which is the US study, 1.1%, that's on top of. Usually it's even higher than that, 2 to 3%, and then sub-threshold, 2.4%. So if you're adding all of these up, you can see you're getting about 5% of the population with bipolar or bipolar spectrum. And this becomes a little bit tricky, I think, in terms of the implications for that. Does that mean that 5% of the population should be on a mood stabilizer? Well, I don't really think so. The other approach to this is what's got quite a lot of traction now is this notion about specifiers. Now, I talk quite a lot about this thing called DSM. That means the Diagnostic and Statistical Manual. It's a manual produced by the American Psychiatric Association. It's an American imperialist approach to the world domination. It's a bit like McDonald's, hamburgers, Starbucks coffee, which isn't coffee, and Krispy Kreme donuts, which are here to kill us all. And like all of those, the DSM is ubiquitous. You cannot escape it. I can't even escape saying it, even though I hate it. And it's very easy to digest, and it's very, very bad for you. And my view is that it actually shouldn't be used in clinical practice. That's my personal view. But we have it. One of the things they were desperate to do when they moved to DSM-5, which there was so much controversy about it, and people, it was embarrassing for the field because people would put up these slides. This was DSM-1, DSM-2 was this thick, the book. DSM-3 was this thick, DSM-4 was this thick, and then they were dreading that DSM-5 was like going to be 2 volumes, and it was going to be, that psychiatrists were just disease-mongering. So what they did was quite clever. Instead of making lots of new disorders, they added these specifiers. So now you can have specifiers on a whole lot of disorders, including in this space. The other thing they did, which was quite clever, was they printed the book on very thin paper. It's true, actually. Jules Angst, which is the best name for somebody involved with mood disorder research, he's a very, very well-regarded researcher in Zurich, set up a Zurich longitudinal cohort, followed people for many, many years. And what he did was to suggest that you could have some changes in your behaviors, your functioning, and irritable, see elevated or irritable mood, or increased activity. So again, capturing these ideas. He called this the specifier, and if you actually look at that in not just the Zurich cohort, but across a number of sites, 5,500 adults with ongoing depression, that about half of them would meet criteria for the bipolar specifier. About 15% would actually have bipolar disorder. Now again, what does that mean? They tend to push this and they say, well, this is validated as a disorder, as a separate disorder. I don't really agree with that, because they haven't shown what is critical to me is that there are treatment implications. There's a whole lot of associations that if you're recurrent depression, you have some of these, what we might call mixed features, that your disorder has a worse outcome and associated with anxiety and substance use and God knows what. But do they respond specifically to specific treatments? We don't know that yet, and I'll come to that later. You can see, well, in DSM-5, what they've done is to emphasize the activity and energy. Already spoken about that in the manic pole, and then they've put mixed features. So you can have mixed features associated with the manic pole. You can have mixed features associated with the depressive pole, and you could actually have mixed features associated even with major depressive disorder, but it doesn't quite meet criteria for bipolar. So that's one set of things I wanted to talk about. Are there any questions so far about? Okay, so now I'm going to, yeah, please.
In primary care, we often will be initiating antidepressant medication for someone that we decide's got major depression only.
Yep.
And then, you know, that sometimes you can unmask a manic sort of phase. Where does that definitionally put somebody there?
Okay, so the question relates to if you only ever get manic or hypomanic on exposure to antidepressants or to ECT, for example. There's a guy called Akuskil who is very keen on these segments of, bipolar 1, bipolar 2, and then he has a bipolar 3, which is exactly what you're talking about. My view, again, is that these are people who have a vulnerability to bipolar disorder, and you're just unmasking it. You can also unmask it, by the way, by depriving people of sleep. So people with bipolar diathesis, you deprive them of sleep for a night, you've got about a 20% chance of them having a manic relapse. You can also precipitate mania with stimulant drinks. Red Bull has been associated, for example. Whether that's secondary to the sleep issue is not clear. There's an important issue, and of course, antidepressants in the mix of bipolar depression is a hugely contested issue, and I'll talk more about that shortly. Let me emphasize then, and it picks up on part of your point, is that the diathesis or the propensity or the vulnerability, if you like, for bipolar is carried with you, and you need to help people come to terms with that and accept that, not in a bad way. It's just saying, well, we need to accept that this is the case, and we need to optimize your care just like we would for somebody with other chronic vulnerabilities like hypertension or epilepsy or diabetes or whatever. So this is an example of a lady who had a prodrome, what was essentially in her teens. She started to become somewhat cranky and irritable, especially by the time of her menstrual period. She started using quite a lot of cannabis, retreating into her room a bit, got a bit irritated with her family, did manage to have this interesting sort of dichotomy. She was able to have only very brief interactions with any parental authority figure, usually grunts, but was able to talk beautifully and poetically to her boyfriend on the telephone for hours. And she would have times when she seemed really happy and outgoing, and other times when she seemed really down for no particular reason. Does this ring a bell with anybody?
Typical teenager.
Yeah. Has anybody here been a teenager? Yeah. So that's right, and this is one of the problems. There's a lot of emphasis now on so-called early intervention, and it's a very tricky area, because that's exactly right. A lot of what I've described is absolutely normal developmental stuff and hormonal-driven stuff. And who would say, well, this is prodrome? Well, you only call it a prodrome because it happens that she did develop a severe manic episode when she did start to behave very oddly and became hugely driven in terms of her motor behaviour, talking 10 to the dozen, engaging in a million project, and started getting to a stage where she was hospitalised. Now, in those days, hospitalisation was associated usually with the introduction of old-style, typical antipsychotic medications. And the one which was ubiquitously used is a drug called haloperidol. Haloperidol goes back to the 60s. It's a drug which essentially is a dopaminergic D2 receptor blocker. It also has some adrenergic properties. But essentially, it's like carpet bombing your D2 receptors in your brain. And that's all very well because it settles your mania down very quickly, but it has sequelae. Because if you carpet bomb all of your D2 receptors, you have a problem with the fact that that stops the reward and other enjoyment components of what dopamine is there for, so you can often get a dysphoria associated with it. You can also get, of course, extrapyramidal side effects associated, stiffness, Parkinsonism, akathisic, this sort of restless, awful restlessness. So, but that was what was used, and she was discharged. And this is one of the beefs of people with bipolar. The system is very interested in me when I'm unwell, in a manic way, but when I'm depressed, well, it doesn't sort of matter so much because I'm not causing much problem. And she became depressed and stayed depressed for a very long period of time. And then eventually she started saying, I'm not taking this medication anymore, stopped the medication, and then became what we'd call euthymic. So this is a usual pattern. Actually got a job, had a relationship, everything was going well, and then she became unwell again in the context of a relationship breakup, started having trouble at work, and really became quite depressed, and then did what exactly you're alluding to, went to her GP as it happened. She either didn't volunteer or wasn't asked, and maybe a bit of both, about the past. So that was the other key part of this decision-making about depression, not just these features that she had about nasty depression, but also she had a background of having had a manic episode. Often these things are very traumatic though, you know, and people try and, or unconsciously suppress. So she had somebody arriving with severe depression. What do? Well, you do a risk assessment and all that, and then you put people on antidepressants. And antidepressants in the context of bipolar 1, which is what she has, are really a no-no, unless in a conjunction with a mood stabilizer. Because what happens, exactly what happened here, she became manic. And so antidepressants, unopposed in bipolar 1, cause mania and induce mania, and also can cause what's called cycle acceleration. And they can also make mixed states, and mixed states I'll come back to because they're particularly difficult. This is...
The treatment of the mania, is that reciprocating the depression?
Well, always the trick with bipolar is there's an underlying mood variability which has a life of its own. And sometimes you have to ask yourself, is what you're actually treating doing very much at all, except dampening? Okay. So whether you're changing the underlying pattern, I think that the old antipsychotics like haloperidol would make those depressive states worse. And there's a dysphoria associated with those states. A lot of people, even with schizophrenia, who've been on haloperidol for a long period of time, you take them off and switch them to an atypical antipsychotics, they describe a sort of lightening of mood and clarity of thinking. So this is an image from a little book called Walking the Black Dog, which is by an ex-patient of mine called Ingi, a really lovely lady who had a similar pattern to what happened in that little description I've just given you. And she described one thing is this notion about the black dog. By the way, I'm not anti-dog here, but this sort of dog thing has got a, and I'll talk about nice other side of dogs for those of you who are dog lovers, okay? There's not an anti-canine talk. But the black dog, made famous by Churchill, of course, actually comes from an old Irish saying, being under the black fog. What Ingi describes quite nicely is the fact that when you're depressed, people often say, well, you just need to pull your socks up and get moving. And she says, and why are you just lying in bed all the time? And she spent a couple of years of her life basically lying in bed. And you can see it's a nice bed with nice butterflies on the pillow. But she says you're actually getting into bed with this dank, horrible, smelly black dog. So it's not like you're removing yourself from it. The other thing which I think she describes beautifully here is this, which I think is a mixed state. So her mind was going, circling round, racing in, racing out, running. So this is a feature of what's called mixed state. So it's when you're depressed that you've got those features which I've described with angst. Okay, is that pretty clear? Yep.
Is that all antidepressants that will trigger off a manic episode?
Yes, some more than others though. So basically SSRIs are slightly less. Agomelatine probably less, I'll talk about that. Bupropion less. And the ones which are really bad are the ones with noradrenergic drive. So SNRIs, especially venlafaxine. Talking about dogs, I'll call venlafaxine the Rottweiler of antidepressants. It's a hugely effective drug, but a bit of a brute. And once it gets onto your leg, you have very great difficulty getting it off, because it, and that, you know, the association is with withdrawal effects with venlafaxine. So venlafaxine is something really to be very, very wary about in bipolar, and also tricyclics, because they all have noradrenergic properties. Rottweiler owners, I apologize. Yes?
If you were to need to treat that episode of depression, would you be happy to start both, say, an SSRI and a mood stabilizer at the same time, or would you just use a mood stabilizer?
Okay, I'll come and talk about that shortly. Okay. So treatment of bipolar depression is very tricky and difficult and contentious. Before we jump into medications, I think the most important part of the treatment of bipolar, as with all psychiatric disorders really, is engagement with the patient, education of the patient, and discussion about psychosocial factors. And as I said, some of the most rewarding work you can possibly do is to empower people with bipolar to take better control of their own destiny, and looking at their strengths, looking at their vulnerabilities, yes, and helping them in terms of optimizing their lives. And actually, psychosocial factors are critically important in terms of outcomes, even if people take their medication, and as we know, anybody with a chronic disease doesn't take the medication from time to time, you get high non-adherent rates. Even if you take your medication, you have a very high likelihood of relapse over years, and a lot of this is contributed by psychosocial issues. So psychosocial stress, negative life events, and family conflict, etc. There's issues associated with the illness itself, of course, as well, which leads to worse prognosis, and that's higher number of episodes, including more manic episodes, actually. There's increasing evidence that it's manic episodes which are really bad for you. You know, people chase this, and you know, sometimes people who are depressed a lot want them, you know, chase the mania. Mania is almost always associated with depression as well, and it makes your brain, it causes trouble for your brain, and makes it less and less likely that you're going to respond to anything in the longer term. So that's one of the really important things to tell people with bipolar. And the other thing is comorbidities. So a lot of people have substance abuse comorbidities, and alcohol, so cannabis, and so forth. There was a little vogue for using cannabis for people with bipolar. It's not a good antidepressant, by the way, but there's a lovely thing on the internet where this guy describes how he used to use cannabis for soporific effects and to help him sleep. And there's a recipe about how you get sauteed in a nice pan with a little bit of garlic and onion, and you have to cook cannabis, you have to heat it to release its THC. Anyway, I'm not recommending this, I should say. But if people are using cannabis and they have bipolar, it does make things worse. And I think it's really important to try and understand why they are doing it, okay? So if they're saying it's because I can't sleep, then obviously you need to tailor your interventions medicinally to help sleep. Always ask why. And also anxiety issues often go along with this. In fact, a lot of the anxiety in our studies show that anxiety drives substance abuse. Okay, so what are the take-home messages about psychosocial interventions? One is psychoeducation. I mean, talking to people about the disorder and talking to people about their particular vulnerability and how they can manage it. And I have a sort of three-stage approach to it. I say the one is the stuff which you can do to help yourself, which is called anchoring. So basically it takes an approach which says all of us should be doing the following, including regular sleep-wake cycle, good exercise, good eating, And there's evidence, for example, that a Mediterranean diet is particularly helpful for mood. So these are anchoring things. Number two would be early warning signs things. So to say, I can actually ascertain when my mood is starting to get either manic or depressed. The obvious one is manic and sleep disturbance. What do I do then associated with myself and my own responsibilities and also my loved ones? I have some we've produced materials for carers of people with bipolar. If anybody wants it, they can email me, I'll send it to them. And that is looking at how one can empower loved ones as well, because they often feel at sea with this. And advanced planning. And the third is the buffering, which is mostly a medication thing. So 1, 2, 3, anchoring, early warning signs and early intervention to prevent relapse, and then buffering using medications. And this has been shown in a number of studies, first psychoeducation from Colom and Vieta in Barcelona, and these are very good long-term benefits, up to 5-year outcomes being published. David Miklovitz in the States done a lot on family-focused therapies. That's quite helpful to involve families and carers. Most of the work's been done with youngsters, and most effective for the manic pole rather than the depressive pole. Then there's this thing called CBT, which is, any psychologists here? So you've heard of CBT? Just a little. So I call it psychologist Prozac, you use it for everybody. It's a little bit passé now, I think, and moving on. I mean, there's a lot of moving on to other models, acceptance commitment therapy and so forth. But I think the core of what CBT does is not a bad thing. But remember, its genesis was largely in depression. And if you look at the interventions for bipolar disorder, the CBT model is more effective for the depressive than the manic pole. The twist to this, though, is that if you look at the early studies from Dominic Lamb, who's a psychologist, they did very nice outcomes. And then a lady called Jan Scott, who's a psychiatrist, got a very big grant, £10 million or something, to do a massive study across the whole of the UK, and it failed. And the reason it failed, rather embarrassing when a very expensive study like that fails and you go back desperately and try and find out why. 2 reasons. One is they tended to start when people were still very unwell. And I think that that's an error. There's an opportunity when people relapse to start talking about and planting the seed and saying, why did you relapse? Let's try and understand that, and what can we do about it to prevent it? But you can't really start the whole therapy thing. So that was one error. The other error was to include people who had lots and lots of previous episodes. So if you cleaved the sample and you looked at those with fewer than 12 episodes, they actually did really well from CBT. Not really well, but they did well from CBT. Those that had 12 or more episodes actually did worse than the controls when they had the CBT intervention. So this is a really important issue. Earlier intervention and prevention of relapse really key. So that's CBT. The other part is the social rhythm therapy, and this is the nice white fluffy Labrador story, okay? I said I'm not trying to be anti-dog here. But why do I say nice white fluffy Labrador? Well, they're so sweet and they're rather stupid and they rather love you and they love coming to lick your face and getting you up in the morning and getting you out into natural light. So that's one of the best things I say prescribe for patients with bipolar is natural light in the morning. There's some beautiful early studies from the 60s, for those of you who remember, that people were investigating, of course you're far too young, they were investigating deep space and looking at whether people could tolerate having no light givers and also social isolation out in deep space. They described how they took a French chap, I don't know why a Frenchman, but anyway, they took a Frenchman, persuaded him to go down into a deep, dark cave with no light, and he would phone up in the morning when he thought it was morning, and he would say, bonjour, send the croissant, it is morning, and they switched the lights on. And then in the evening, he would phone up and say, bonsoir, it is nighttime, and they switched the lights off. And he entrained quite quickly into a 25-hour clock. And it wasn't just because he was French. This has been shown, humans tend to have a 24 and a half to 25-hour clock. So that says to me, every morning you've got to reset your clock and reset, through your... And how do you reset? Well, you reset through light impinging on your retina, going to your pineal gland and resetting. So this is a really important part of it, and that's the social rhythm part. Okay? We put this together in a thing called collaborative therapy. Again, I won't go on about it, but I can send the papers. It's basically taking all of these elements, putting them together, and including family as well. This is one thing which I think is critical for everybody with bipolar to have, and that's a mood diary. Very empowering and also allows you to ascertain what the hell's going on. For example, if you change medications, what the efficacy or otherwise is. So this says the day and the date. There's an overall rating for the first half of the day and the second half of the day, and then sleep. And you can comment here. So menstrual period, work stress, change in medications, whatever. And you just, 10, I'm very simple-minded here. So 10 is, 0 is just awful. 5 is sort of normal, and 10 is wonderful or over the top. And people usually, they get a sense for themselves. This is what our program looked like. It was much about education. It was about monitoring and assessment, as I've already gone through, prevention of relapse, goal setting, and then bits about depression, bits about mania, and then integration into daily life. Not advertising, but advertising. There is a book called Living with Bipolar. The first author is Leslie Burke, and we give that to patients as well. And this is very effective in terms of both relapse of manic and relapse of depressive episodes, and that's how it looks. Any questions about that? All right. So that's really critical, this stuff. And also, by the way, there's a thing called Mood Swings, which is this program, which is an online version of it, which some people find helpful as well. So you can send patients to that too. Now let's look at bipolar mania, then bipolar depression in terms of medications. Mania is relatively easy, actually. But what I would say to you is that, so that's this poll. What I'd say to you is that the really important thing is to treat in the short term with a view to the long term. So if you look at, this is a meta-analysis of studies. I hope everybody's got these slides. If not, please, I can send. What the evidence says, so this is from a meta-analysis. Always be a bit suspicious about meta-analyses. And don't have, because meta-analyses are too simplistic. They take a massive amount of data, put it into a computer, and it spits out a single answer. So this says, well, haloperidol is the best. And if you take that message, I think that you're doing your patients a disservice. That's how it comes out in terms of the effect size being the largest. Partly that's because, of course, there's so many studies with haloperidol, and partly because it is jolly effective in mania, acute mania, but it's not nice to take. About 7 to 10% of people get dystonias, a lot of people get akathisia, and as I said, in the long term, you get this dysphoria. Also, it raises your prolactin, which isn't a good thing for bone density and other reasons. So you can see these other drugs, risperidone, olanzapine, lithium, quetiapine, asenapine, sodium valproate, antiprosidone, all have a signal. The ones which don't are gabapentin, lamotrigine, which is useful for bipolar depression but not mania, topiramate, and those were no better than placebo. So what do you actually end up doing in clinical practice? Well, often it's landing up using a very easy-to-use drug like olanzapine because it's sedating, and that's helpful in bipolar. The problem with olanzapine, though, is that it is a very nasty drug in the long term because of the metabolic effect. So it causes, in most people, not everybody, but a lot of people, causes a lot of weight gain. It also has an independent signal for diabetes and raises your triglycerides and all sorts of issues. And these are very tricky in the long term. So our own view is if we use it in the immediate term, you don't treat through with it and you switch to something else. But sometimes it can be useful in the very acute phase. Lithium, well, lithium has some benefits, but the problem in the acute manic phase is it's quite tricky to use because it takes 10 to 14 days to really kick in. It's not terribly sedating. And you do have to take it. There's some evidence that if you stop and start lithium, you actually make things worse for yourself. So you really got to have people on board and taking it. And it does have problems with thyroid and renal and other problems. And it's actually, for common or garden bipolar, that's with when I went in without rapid cycling and without mixed features and without psychosis, then it's not a bad bet. But that's relatively milder type, right? Quetiapine is a very, very useful drug and has very good credentials in the long term with bipolar. It does have a signal also for weight gain, but not as severe as for olanzapine. And the one I just wanted to pick out here is valproate. So valproate is an anti-convulsant, as you know, but has a lot of use in the bipolar space. I think overused, and this is partly because it was driven by certain, again, mostly American researchers who actually the data are very poor for valproate. And even the initial studies were really not very impressive, but it does help in the acute phase. The problem is, as I said, treating in the acute phase with a view to the follow-up. So valproate do not use, in my view, if you're a young female, because it causes weight gain. It causes polycystic ovarian syndrome. It's highly teratogenic. About 50% of infants born to moms on valproate will have some, albeit very subtle, neurological problems, and sometimes very severe, so really, I think valproate is vastly overused, and they're much better alternatives. So that's the acute mania, but that's relatively simple. The acute depressions, the depressions are much more tricky. And here there's a whole lot of considerations, including the longitudinal course, the propensity to switch. I already answered this question. Tricyclics worse than SSRIs, for example. Now, this is, again, a meta-analysis. As I said, there's all sorts of caveats and problems with meta-analyses, but it says essentially, if you look at these, they're not actually that effective. So this is a reasonable number of patients, very modest benefits. In fact, that transgresses one in terms of the confidence limits. So actually, antidepressants aren't all that helpful in bipolar depression. Having said that, everyone in this room would have used them in bipolar depression. My own view is you shouldn't use them unopposed. And there's debate about how long or short you use them. There's some studies, those studies are mostly based on randomized controlled trials. Now remember, the randomized controlled trial data are very biased because you only get into a randomized controlled trial if you're not a female of childbearing age, if you don't have substance abuse comorbidity, anxiety comorbidity, etc., etc., etc. So only, in your clinic, only about 10 to 15% of people with bipolar would actually get into such a randomized trial. So it's a very biased group. So this is an attempt by the NIMH to look at a more generalizable sample. It's a sample called STEP-BD, nice big sample of patients, 2,500 patients. And there's a couple of analyses from this study which are really quite instructive. One is from Gary Sachs, and what he did was to do a random allocation of people coming into STEP-BD to 26 weeks. That's the other thing in bipolar is, of course, it's a long-term illness, so to look at any significant outcomes, you have to look over the long term. So he randomized them to a mood stabilizer. That means lithium or valproate, by the way. And bupropion. Remember, bupropion is not available in Australia for mood problems. It's only a Zyban for smoking cessation, but it's got quite a good credentials for bipolar depression. And it's a noradrenaline dopamine reuptake inhibitor. No serotonergic properties. Paroxetine, which is an SSRI, my least favorite SSRI, I should say, for various reasons, but I won't, including withdrawal problems and sexual problems, but or to placebo. And basically, none of these differed from each other. So it didn't seem to add anything over and above a mood stabilizer. So that's one way of looking at it. The other way to look at it is what Joe Goldberg did, again, nested within the STEP-BD sample. And what he did was to take people who had one manic-like symptom, so sort of one of those mixed features. The most common, by the way, is what I showed you with Ingi's drawing, is severe, horrible mood, but with this racing. Okay? And if you put them on antidepressants, again, they do no better in terms of depressive relapse, but they actually get more manic-like symptoms. So it actually makes things arguably worse. Now, put that on one side, and we'll talk about this study. So Gordon Parker is in Sydney, and a lot of respect for him, but he tends to say, well, actually, antidepressants aren't so bad in bipolar 2. He would agree in mixed states, don't use them, and in bipolar 1, certainly not unopposed. Are they so bad in bipolar 2? Well, he quotes this study, some of his own studies as well, but quotes this study from J. Amsterdam. And what they did was to take a 50-week randomized trial of fluoxetine versus lithium versus placebo. But what they don't emphasize enough is that all of these people who went into this study had responded well to fluoxetine. So even though they had bipolar, you're rarefying the sample. You're making it an enriched sample for fluoxetine responders. And the other thing is that they don't emphasize enough is then if you switch people, for example, to a placebo or to lithium, any switch is associated with a greater likelihood of relapse. And what they showed is that, well, depressive relapse there was a longer delay to depressive relapse in the fluoxetine group than the placebo versus the lithium group. I think this is very misleading for the reasons I've articulated, and I would strongly advise to take this with a large dollop of salt. What is likely to switch people? Well, if that had previous mixed features, depression preceded by mania, hypothalamic temperament, that's these rather irritating people who are always a little bit over the top and a little bit bubbly and a bit intrusive. Some of you might be like that. I'm sure you're lovely people, but you can be irritating to others. Bipolar 1, obviously, rapid cycling, so that's when you get more than 4 episodes per year of either up or down. Past history, obviously, a switch, comorbid substances, and SSRIs, bupropion, less than the SNRIs and the tricyclics. Agomelatine an interesting drug because it's a melatonergic M1 agent, also has postsynaptic 5-HTC receptor blockade. Because it helps circadian rhythms, you would think it might be quite helpful in bipolar. There aren't any randomized trial data to support this. I've used it in a few patients, can be quite helpful. Lamotrigine, though, is a very interesting drug. So lamotrigine, as you know, is an anticonvulsant, but it has very good cred, and I think is almost the drug of choice for bipolar 2. And again, Gordon Parker would agree with this. Remember, though, the problem with it is it can cause skin problems and Stevens-Johnson syndrome in some patients, so you've got to start very slowly. And if you look at the acute data in acute depression, it's not all that helpful partly because you have to build it up. But in the long term, it almost acts like a cushion under we talked about the buffer. Well, I think it buffers the depressive pole really nicely. So if you have bipolar 2, especially with a lot of depression, throwing in lamotrigine is very, very helpful. And you start 25 milligrams a day for a couple of weeks, then 25 milligrams twice a day, then go up to 100 milligrams a day. And I usually stop at 100 milligrams a day, but the data are usually about 200 milligrams a day. Very, very helpful drug and very well tolerated. Also, if you have patients who are on lithium and are doing okay on lithium, but just still have some residual depressive symptoms, putting lamotrigine into the mix can be really helpful. There's a Dutch study, which shows exactly this. Olanzapine, I won't go on. I'm going to finish here with quetiapine. Olanzapine has its problems, as I said. I mean, it can be helpful enough, but quetiapine really has excellent credentials in bipolar, and arguably, along with lithium, is probably one of the 2 true mood stabilizers in that it helps the depressive pole and the manic pole and doesn't make either of them worse. An antidepressant isn't a mood stabilizer because it only works on one pole, so the depressive pole, and it makes the other one worse. Okay? This works from both sides. And there's lots of very, very, very consistent data. I often use it. The problems associated with the gain are weight gain, but it's less than with olanzapine, as I said. And you've got to monitor that. And all of the healthy lifestyle stuff I talked about at the beginning are really important. What I often do is to put people on about 300 or 400 of the slow release. It's a better formulation. It doesn't bomb you out just like the instant release one. So you take about an hour before bed. Usually gives you good coverage right through the day. Sometimes I would add 25 milligrams of the immediate release as a sort of PRN, and the patient actually learns to use that. So if they're monitoring their mood carefully, and the early warning signs of a manic relapse are things like not sleeping so well, which is a very common one, as I said, adding 25 milligrams of the immediate release as they go to bed is really, really helpful, and just in the short term. And again, it's part of empowering the patient. Remember, there's an issue with prescribing the immediate release, 25 milligrams, you can't get any repeats, partly because it has an abuse potential and is quite popular in the people who use a lot of stimulant drugs to bring them down. So I think that that's as much as I have time for. I'll just leave this to say that there's plenty we don't know about, and there's various approaches to resistance, and often we land up with mixtures of medications for bipolar. But I hope I've emphasized for you the importance of psychosocial interventions and all of those things which I've talked about, the anchoring, the early warning signs, and early intervention for prevention of relapse, and then the buffering effects of medications. There's a section on this slide set which is more about prophylaxis, and I'm very happy for you to have that, and also can point you in the direction of various pieces of written information if you wish. So are there other questions?
5 minutes for questions.
Yeah. I have a 40-year-old who I've looked after for 14 years with bipolar, complicated by PTSD and personality disorder. I have a couple of questions. The difficulty is scheduling for loss of reputation, which I think is quite a grey area. When they talk to psychiatrists about it, because they haven't known them as long as I have, and what do you suggest to overcome that?
Scheduling, you mean under Mental Health Act?
Could you
Over
explain the question?
the psychiatrist?
Sorry?
Over the psychiatrist?
So scheduling.
The psychiatrist didn't want to schedule them.
Okay, so I'm just making sure, because the scheduling you mean. So the question, as I understand it, is when would you use the Mental Health Act? Yeah. So you use the Mental Health Act, I mean, as you know, and certainly Victoria, we just got a new act, and I think you're getting a new one here as well, which is very much about, it's almost over favourable towards the patients in a sense. You know, I mean, I'm supportive of this whole idea of people taking responsibility for their stuff, but they've got to take responsibility for their stuff in the long term, and they've got to understand that certain decisions which they might make might have bad effects. So, for example, using drugs, for example, not taking the medication. We're finding it increasingly difficult to persuade Mental Health Review Tribunal that the past should be taken into account in decision making. So you can point to people who've had bad relapses and have landed up in all sorts of trouble, including reputational trouble, and then they'll say, oh, but now they're saying that they'll take the medication, and now that's a very hard thing. And I think that what we can do is to go and try to be clear and advocate ahead of time with our patients about what is likely to happen if they become unwell again, and agree with them what the early warning signs might be, and agree with them what everybody around them could do to help them, including us as a GP or as a psychiatrist. So a lot of it's now, to my mind, about forward planning. And again, I can send you some our material, which is ready for carers, but which also within that package is the relapse prevention planning and what you do when you're facing a relapse. The other thing I'm sure is the same here as in Victoria is our inpatient units under the public sector are just a nightmare, largely because of the ICE. They're violent, aggressive, horrible places to be, unfortunately. So it's no great haven, unfortunately.
I was wondering how much we know about what happens with the brain and neurotransmitters.
Well, we actually kid ourselves that we know an awful lot, whereas I think we actually know increasingly little, or we're realizing more and more about how little we know. We do know that there are perturbations of certain neurotransmitters, including dopamine, serotonin, adrenaline. We also know that some of the medications we use have nothing directly to do with such things like lamotrigine, for example. It's essentially a calcium channel blocker. And valproate works in mysterious ways. Lithium acts in very mysterious ways. Yes, it's got some serotonergic properties in the frontal lobe. It also has effect on BDNF, and it seems to protect the brain in certain ways. But to be honest, a lot of our field is still serendipity. So use medications because we found serendipitously that they work.
I guess I'm showing my age. When I started, we were still using tricyclics, and SSRIs were new kid on the block.
Yep.
And of course, in those days we were using haloperidol,
Yep.
which I must say, my experience was quite effective. And then the new agents that come out, and facetiously, I think of the latest things, a little bit of haloperidol, and some Valium, and some, some periactive to make it fat.
Yeah.
So my question really is, what is the role of haloperidol in acute pain?
Yeah, look, it's a fair question. I think the role of haloperidol in acute mania is very, very, very limited. In fact, the only, and because you can get away with other drugs, and if you're going to have to use a PRN drug, olanzapine is not a bad one. We like it. I work in a Catholic hospital, and it comes in wafers, so we like it a lot. But seriously, it's also, you can use it intramuscularly, intravenously even. It can be very helpful, but don't discharge the patient on it. Certainly not as a first-line drug because of the longer-term problems. But to bring people down, it can be quite helpful. The only place we're using, in fact, droperidol rather than haloperidol is for ice intoxication, because these are people who are usually quite healthy young people who have a massive surge of adrenaline and dopamine, and they are a nightmare to deal with and physically very violent. So there we've gone back, in some cases, to droperidol, which basically very tenacious for D2 receptor and has some alpha receptor blockade as well.
It's used widely in emergency departments here too for
Yeah.
put a blanket over somebody. Time's out now, so let's thank David for an excellent